We are live. Hello. Good evening, viewers. Welcome to Diabetes Bytes, the 55th episode's social media initiative from RSSDI. We are live every Thursday between 7:30 and 8:30. And today, we have an interesting topic, not covered usually, because this is not spoken, and I'm very proud to moderate the session. I'm Dr. Sanjay Reddy from the RSSDI social media team and representing the executive committee of RSSDI. Today, we have two guests with us. One is Dr. Tejal Lathia. Dr. Tejal is an endocrinologist who practices in the city of Bombay. She is from Navi Mumbai. She has a lot of credentials which I can't keep on talking. She's a well-known orator, a good speaker, and that's what has taken her to start something as an initiative, probably a practice which said that she has to do something with communication. So what today's subject is what doctors say and what patients hear. And joining her is Dr. Chitra Selvan. Dr. Chitra Selvan is also an endocrinologist from the city of Bangalore, from where I am, and she practices at MS Ramaya Medical College. She's an associate professor at the Department of Endocrinology. Never hides anything, speaks her heart. A good friend and somebody who I can open up and discuss anything on the earth. So welcome, Chitra, and she's a very good orator like Tejal, and both of them, both young superstar women endocrinologists of this country. Thank you for being on the show, and it's my honor to moderate. Lost in translation, that's what we say. We were never taught. When I was in medical school or when I studied, we had these temper tantrums which I could see between patients and doctors, both the ways. My professor would throw the file of one of the patients and say, I told you this and you didn't follow, so don't come back to my clinic. So I don't know if that is any more allowed in today's practice, but anyway. And the patient would come and say, what is this? It's either way. That means communication. That's the key. And what these two young ladies have done today is taken up this communication into a different world and trying to teach all of them as to say, can we communicate better? Can what we say, the patient understand better? Can we listen more to the patient and make sure that our diabetic people, I don't call diabetic patients, the people with diabetes who come to your clinic, can we make them better people and make sure they don't become patients? But in this process, there's a lot to learn and a lot to communicate. So taking this, and I start off with Tejal. Thanks for being on the show once again, Dr. Tejal. So
thank you.
What made you get into communication skills, communications between doctors and patients? You've been doing this work for quite some time. I read even your article today, the full article on diabetes and social media, social issues. Thanks for putting me on the show. So I had to do some homework on both of you and on your community. Though I've listened to you, both of you recently at the debate, but how did it all start? And would like to hear from you how this whole issue with communication among patients and doctors start.
So first of all, thank you for the kind invitation, and we're really happy to be here. And just coincidentally, this today happens to be the day that I lost my mother very, very time back. And my mother suffered from high blood pressure. And every time she would go to the doctor would just mumble something, write a medication and say, you have to take this lifelong. And when you say that to a person that you need to take this lifelong without any explanation about what can be the repercussions of high blood pressure, why she needs to take the medication, so she would end up never taking the medication. And then she would go back, the blood pressure would be high. And again, the doctor would say the same thing. I told you to take the medicine, you didn't take it, you don't listen to me. And as you said, don't come back to me. So, and then when you go home and then people around you tell you, oh, you shouldn't take medicines lifelong, it will spoil your kidney, you will become dependent on it. And because of this entire thing, my mother had a massive cardiac arrest and I lost her at a very young age of 11. And ever since that time, I remember in the last consultation we had with the doctor the day before she died, I'd accompanied her. And, I came home and told the family, oh, that's what the doctor said. The doctor said it's very serious. She needs to take medications. Things are really bad. And I think that kind of left a huge impact on my mind. A few years later, my father also experienced diabetes. And, I remember the stories he used to tell us about his interaction with his doctors. And I always felt if only somebody had taken the time to explain the situation better to them, maybe had listened to what their concerns were, they would have actually complied with the treatment and I would not have to lose my parents. So I think that's where the entire thing started in my mind, that we need to do something. That's why I became an endocrinologist, because my father had diabetes and I thought that if I become an endocrinologist instead of a cardiologist, I can prevent a heart attack from happening than actually just a person has a heart attack and I do something about it. And that's why I chose endocrinology as well. So the journey started with, Dr. Partha Kar from the UK, who they came up with the Language Matters document for the United Kingdom. I read it and I thought, wow, this is great. But what I also realized is that maybe the story is not the same as it is in India. Maybe people in UK who have diabetes have a different experience and we have a different experience. So what we set about doing is we had a series of focus group discussions where we actually invited patients to sit down with us. We asked them about their experiences, we recorded it, we transcribed it, and then through all that wealth of data we accumulated, we were able to come up with this document called the Language Matters. We had one-on-one interviews. And what I can just share with you is the overall impact of all these focus group discussions. I remember Chitra and me calling each other up and we were horrified. We were literally horrified with what people were experiencing. People were upset, they were angry, they were frustrated with the kind of care they were receiving. They had no problem with the medical care. They knew that they were getting good medications, but it was the communication, how what the doctor said made them feel. That was a source of great sadness and despair for patients. And some of these were our own patients we'd been seeing in clinic, who we thought that the patients liked us. So, we all think that, oh, my patients like me very much. Yeah, they will talk nicely about me. Well, hello, it doesn't work like that. So even though it was not a direct criticism, they knew that maybe Dr. Tejal will look at this at some time. But yeah, there were really bad experiences, not so great experiences. And I think it's a privilege to be able to kind of record what people experienced, be able to share it with doctors. And of course, we'd like to clarify, as we clarify in the document right at the beginning, the intention of this Language Matters journey is not to make doctors feel bad about the way they are communicating. It's because they have never got the formal training. They've never been explained how to do it. And I think it's a skill that you have to learn just like anything else.
So thank you, Tejal, for sharing a personal experience. I think we all have gone through something like this in our life. And that's very nice to share something personal. And the endocrine community and the city of Mumbai where you practice, a privilege to have you because you choose endocrinology rather than cardiology. So thank you for that. And Language Matters and Partha, I had interacted with Partha a couple of times, and I also was responsible. We released the Language Matters first time in Diabetes India, a meeting last year in February. It was very nice for both of you. You did a lot of focus group discussions. Not easy to call your patient back and tell him, oh, come on, tell something about me. Then I remember this, some wise doctor saying, it's not the patients don't remember prescriptions. Only thing they remember is a communication. So saying this, Dr. Chitra, welcome once again. I want to ask you, when did your journey start? And I think you had two group discussions, one in Mumbai, probably you had a series of them. I know a couple of them. So would like to know about your interaction and how all it started. Chitra, we're not able to hear you.
Chitra, we can't hear you.
We can't hear. Mostly, can you fix it up? We can't hear you.
Can you hear me now, Tejal?
Yeah, you're right. Yeah, we can hear.
Yeah.
Can you hear me now?
Yes,
Yes.
yes.
All right. Sorry. I'm sorry about that. Yes, I had as well. My mother had very early ILD, and her only complaint was she had effort intolerance on exercise. And all pulmonologists brushed aside her symptoms, saying, why is a 60-year-old lady complaining that she's not able to do 12,000 steps? Right? That's the only thing they kept saying. Saturation is fine, 6-minute test is fine. Why are we treating you or paying attention to you? But for my mother, that was an extremely important symptom, right? So that was restricting her activity, her exercise was coming down, and she was worried that she's going to become less fitter, take care of her diabetes. So I did the rounds of quite a few pulmonologists in the city until I found a person who was willing to sit her down, listen, and say, maybe you're having a can probably dig into that. So that was the point. I woke up, and as serendipity would have it, I bumped into Tejal, who was also thinking about the same things, and started to write. When we reviewed all the other language matters documents, we realized that most of them where anecdotal experiences or maybe expert they think is right or wrong. But one thing kept nagging in our minds: is it true that Indian patients are different? There is maybe these are very first world problems, and not really. That was a thing which was being thrown at us very often. So we thought we should go straight to the patient and ask them exactly that. And as Tejal has highlighted, these were patients who thought loved us, who to spare 2 hours, and this was right at the start of the pandemic, just when there was an impending lockdown, at least in Bangalore, where they came to a hospital setting, which is a risky set, masks with physical distancing, and spent about 2 to 2.5 hours with us, sharing their experiences, while they all started out saying, you know what, I do love Chitra, great for me, but there were many things which even I was doing which was causing them hurt. Like, for example, the fact that I have used vague analogies to explain to them on insulin that your beta cells are like dead horse is a word, Tejal, which a patient pointed out to us
I
and
think
said
many
that is
people.
dreadful. Don't ever say dead horse. Flog, like, why are you equating me to animals? And this was an animal activist who pointed it out to us. He's like, do you understand that these kind of analogies are like ridiculous and they don't get the point across? Scientifically explain it to me without bringing up ridiculous similes, assuming that I'm stupid. Right? We do that, right? We infantilize our patients, think that they might not understand if we eclay, and tend to use these similes which they find ridiculous. So when Tejal and I were listening to the audio scripts, we were overwhelmed to say some of the our patients, and we had no clue at all. And right after we saw that, we knew we had to get the language matters document out, but we also knew that to get the scientific community to and to take the words of our patients seriously, we had to get a scientific analysis done of the work that we had done and get it published in respected journals. Exactly what we've been doing this year, and I'm extremely proud of the work we've been doing, because this work is difficult. Qualitative analysis is a whole new ball game, and we have no idea how to go about it, but we are getting all the help that we can, pulling out threads, doing the thematic analysis, and we are looking forward to a great paper where then my more nerdy colleagues will not look at language matters document and just say this is just all Tejal and Chitra, the touchy-feely women who've pulled out this document and now getting us to do more things to feel for my patient, and those are difficult things to do. Don't ask me things. Just yesterday a resident got beaten up, and that's been playing on everybody's mind for the last 2 days, and we know it's disturbing, right? We already feel like we're doing too much. We already feel like we're giving our life, so now you're coming and tell me go cry in the clinic with your patient. So we're trying to beat that up with scientific evidence, and that's exactly what the FGD led us to, with in terms of elected from patients who loved us. So we're hoping that the document will be out, and we'll send across a copy to Dr. Sanjay Reddy, and it'll be out in the public domain for everybody to read. Dr. Sanjay.
Thank you, Chitra, for sharing your experience and how you got into and what happened with language matters so far. Dr. Tejal, wanted to ask you a couple of. You had some patient. You can speak in Hindi too. आप बहुत सारा पेशेंट को लेके उसकी सोच और समझ को you wanted to understand them. So you can speak in Hindi too for an audience as what the patients feel about what doctors think and how they talk.
Okay.
Based on the group discussions, I think you had a couple of them.
Yeah. So हमारे focus group discussions में हमारे लिए बहुत कठिन था, बिकॉज मुझे और चित्रा को लगा कि हम बहुत अच्छे डॉक्टर हैं, हम बहुत अच्छे से पेशेंट से बात करते हैं, हमारे पेशेंट हमको बहुत पसंद करते हैं, और जब वो क्लिनिक छोड़ के जाते हैं तो थैंक यू डॉक्टर, हमें बहुत अच्छा लगा आपको मिलके, एंड हम आपको जरूर 3 महीने के बाद दिखाएंगे. यू नो, दिस इज द यूजुअल काइंड ऑफ कॉन्वर्सेशन दैट अ पेशेंट लीविंग द क्लिनिक सेज. पर जब हमने ये पेशेंट्स को इकट्ठा किया, अबाउट 30 पेशेंट बॉम्बे में और 30 पेशेंट बैंगलोर में, और पेशेंट जब बैठे तो वो सब बहुत ही दुखी थे. उनको सेटिस्फैक्शन नहीं हुआ डॉक्टर को मिलके, और वो इसलिए नहीं कि क्योंकि उनको दवाई अच्छी नहीं मिली, कि उनको डायग्नोसिस सही नहीं मिला. तो यहाँ पे मैंने ये जो आज का प्रोग्राम है उसका नाम लॉस्ट इन ट्रांसलेशन इसलिए रखा है बिकॉज मुझे ऐसे लगता है कि मेन प्रॉब्लम ये है कि डॉक्टर्स भी अच्छे हैं और पेशेंट्स भी अच्छे हैं, लेकिन डॉक्टर्स जो कहना चाहते हैं तो पेशेंट के अच्छे के लिए कह रहे हैं, लेकिन वो उसको ठीक तरीके से नहीं कह पाते, और वो जो शब्द इस्तेमाल करते हैं वो पेशेंट को दुखी करते हैं, उनको बुरा लगता है. डॉक्टर्स अपना समझ के डांटते हैं कि जैसे अपने खुद के रिश्तेदार को डांटेंगे, लेकिन हमको ये याद रखना है कि हमारे सामने जो आदमी बैठा है वो बेवकूफ नहीं है, वो कोई कंपनी का सीईओ हो सकता है, कोई स्कूल का प्रिंसिपल हो सकता है, वो कोई बड़े से कंपनी में मैनेजर हो सकता है. और जब हम उनको डांटते हैं वो उनके जो ईगो को हर्ट करता है, उनकी सेल्फ एस्टीम को हर्ट करता है. और जब पेशेंट अपने से दुखी है वो हमारी दवाई कभी नहीं लेगा. वो आपके सामने अच्छा अच्छा बोलेगा, यस डॉक्टर थैंक यू वेरी मच, लेकिन वो वापस नहीं आएगा या तो वो आपकी बात नहीं सुनेगा. तो एज अ डॉक्टर मेरा एम क्या है कि मैं अपने पेशेंट को दवाई ऐसी दूं कि उसका डायबिटीज कंट्रोल रहे और वो अच्छी जिंदगी जिए. अगर ये चीज मैं अच्छे से उसको समझाऊंगी तो वो मेरी गोली लेगा, उसकी शुगर कम होगी और वो अच्छा रहेगा. लेकिन मैंने दुनिया की अच्छे से अच्छी गोली दी, लेकिन मैंने उसको ठीक से नहीं समझाया, मैंने उससे ढंग से बात नहीं की, मैंने रिस्पेक्ट से बात नहीं की, मैंने सुना नहीं कि वो क्या कहना चाहता था. हाँ हाँ ठीक है ये गोली ले लो सब ठीक हो जाएगा. तो अगर मैं अच्छे से सुनूंगी नहीं या बात नहीं करूंगी तो फिर कितनी भी अच्छी गोली हो वो पेशेंट ना तो लेगा ठीक से, या तो वो लेगा तो उसका वो असर नहीं आएगा, और अल्टीमेटली मेरा जो एम था कि मेरा पेशेंट ठीक रहे वो कभी पूरा नहीं हो सकता. तो आज हम सिर्फ इतना कह रहे हैं डॉक्टर चित्रा और मैं कि डॉक्टर अच्छा है, वो अपने पेशेंट का भला चाहता है और वो अच्छे के लिए समझाता है, लेकिन बस उसका तरीका अगर थोड़ा सा बदल दे तो वही चीज बहुत ज्यादा अच्छा इफेक्ट देगी. पेशेंट्स को मैं डेफिनेटली ये कहना चाहती हूँ कि आप कितना भी आपके आजू बाजू जो चल रहा है उसके बारे में सुने, लेकिन इतना ध्यान रखिए कि जो भी इंसान डॉक्टर बनता है 13-14 साल की कठिन पढ़ाई करता है, वो इधर टाइम पास करने किसी का नुकसान करने डॉक्टर नहीं बना है. और पेशेंट का नुकसान करके हमको कभी फायदा नहीं हो सकता, क्योंकि अगर मैं पेशेंट का नुकसान करूंगी तो वो 10 पेशेंट को जाके बोल के आएगा कि वो डॉक्टर बहुत खराब है, उसके पास मत जाना. वो हमारे हित में नहीं है कि हम आपका नुकसान करें, लेकिन हाँ, हमारा तरीका ज़रूर थोड़ा गलत हो सकता है, हमारे वर्ड्स कभी-कभी हार्श हो सकते हैं, आपको उसको सुन के अच्छा ना लगे, लेकिन हमेशा ये याद रखिए कि वो जो हम कह रहे हैं, वो अल्टीमेटली आपके भले के लिए है, क्योंकि आपका अच्छा होगा तो पेशेंट को, डॉक्टर को खुशी मिलेगी, उसको सुकून मिलेगा और उसने जिसके लिए इतनी सारी पढ़ाई की है, उसका उसको फल मिलेगा। तो डॉक्टर आपका नुकसान तो डेफ़िनिटली नहीं करना चाहता है और वो आपका अच्छा ही चाहता है। शायद उसके शब्द जो वो इस्तेमाल करे वो गलत हो सकते हैं। वो इसलिए भी हो सकता है कि उसको कभी सिखाया नहीं किसी ने कि आपको कैसे बात करना है। डायग्नोसिस बनाना हमको सिखाया है, खून कैसे निकालना है, दवाई कौन-सी लिखनी है, साइड इफ़ेक्ट क्या हो सकता है, ये मुझे सब कुछ पता है। लेकिन बोलना कैसे है, पेशेंट को समझाना कैसे है, कोई बुरी खबर कैसे बतानी है, ये हमको कोई सिखाता नहीं है। तो अगर आप चित्रा या डॉक्टर संजय या मेरे जैसे हो जो अच्छे से बोल सकते हैं, कॉन्फिडेंटली बोल सकते हैं, तो हम सामने वाले को समझा देते हैं। लेकिन हर डॉक्टर को वो कम्युनिकेशन स्किल नहीं होती है और उसकी वजह से कभी-कभी उसके बोलने का तरीका गलत हो सकता है या वर्ड्स हार्श हो सकते हैं, लेकिन उसका इंटेंशन हमेशा ये है कि आपकी सेहत अच्छी रहे।
थैंक यू डॉक्टर तेजल। एंड मैं यही बोलना चाहता हूँ, आप डायबिटीज की पेशेंट नहीं है, डायबिटीज रहने वाला लोग है। यू टॉकिंग टू पीपल फर्स्ट एंड फॉरमोस्ट, एंड देन द सेकंड मोस्ट इम्पॉर्टेंट थिंग, जो बोलने की तरीका है, द वे वी स्पीक टू देम एंड कम्युनिकेट, इट्स द मोस्ट इम्पॉर्टेंट थिंग। एंड थैंक यू फॉर गेटिंग अस। Nobody, many people in this world wouldn't want to come and जो भी है, जो भी डॉक्टर है, वो भी वो समझता है जो भी वो बोला है, like Dr. Tejal told that this is the best, I know everything about the treatment. We're not taught about how to communicate. So yeah, this is very important, and please note that even the patient also should behave in a similar manner. We'll go back to that. Dr. Chitra, I had a small question that both of you conducted a lot of surveys in terms of healthcare workers survey, which is part of your part of understanding how doctors, patients, and healthcare workers communicate to patients, and who is better in these communication skills, and what are the lessons, or what lessons did you learn from this survey?
ओके, मैं हिंदी में बात करने की कोशिश करूँगी। तो जब हमने सारे पेशेंट्स की कहानियाँ सुने, फ़ोकस ग्रुप डिस्कशन के बाद में, हम तो अलग सिचुएशंस में, अलग-अलग कंपार्टमेंट्स में डॉक्टर ये कहते हैं, जैसे शुगर कंट्रोल में नहीं है तो आपका किडनी फेल हो जाएगा, आप 10 साल कम जिएंगे, आपका किडनी फेल हो जाएगा, आपका हार्ट अटैक हो जाएगा, ऐसे कठोर वर्ड्स यूज़ करते हैं और ये पेशेंट्स को अच्छी नहीं लगती है। तो ये लिखा गया था, जब हम इंसुलिन बोलते हैं तब भी कुछ ऐसे बोल जाते हैं जो पेशेंट को अच्छा नहीं लगता है। तो ये 2-3 घंटे पेशेंट की बात सुनते-सुनते मैं और तेजल इतना परेशान होके बैठे थे कि क्या कुछ भी अच्छा नहीं लगता है डॉक्टर की वजह? क्यों पेशेंट को ऐसा लग रहा है कि सारे डॉक्टर उनको चोट पहुँचाना चाहते हैं? दैट वाज़ द थिंग। बट हम तो ऐसे नहीं सोचते ना, क्लिनिक में जब जाते हैं हम तो आपकी इलाज करने के लिए आए हैं। जो भी, जैसे जो डॉक्टर तेजल ने बोला है, जो भी डॉक्टर बना है कोई हार्म करने के लिए तो बिल्कुल नहीं है। तो इंटेंट डॉक्टर की, मगर जो पेशेंट तक पहुंच रही है वो तो कुछ अलग ही बन के पहुंच रहा है। तो बीच में वो क्या है जो ट्रांसलेट नहीं हो रहा है, तो ये पता करने के लिए हमने सोचा, पेशेंट की बात सुनी तो वो डॉक्टर के लिए ठीक नहीं रहेगा। डॉक्टर का साइड ऑफ द कहानी भी पता करना है और उसको भी बताना है, ठीक है? तो हमने डॉक्टरों से पूछा कि आप बताइए, जब मिलते हैं आपको क्या कभी गुस्सा आता है किसी पेशेंट के साथ? किस दिन गुस्सा आने के चांसेस ज़्यादा है? आपके पेशेंट आपके क्लिनिक में कितना घंटा वेट करते हैं? कितना घंटा वेट करवाते हैं? उनके अंदर बुलाते हैं? क्या आप हेलो बोलते हैं? क्या आप पेशेंट से पूछते हैं, आज आप किस तकलीफ के लिए मेरे पास आए हैं? क्योंकि हमें सारे कॉन्फ्रेंसेस में, सारे कॉलेजेस में डायबिटीज़ की पेशेंट ट्रीट कर रहे हो तो पहले HbA1c कम करो, फिर ब्लड प्रेशर कम करो, फिर कोलेस्ट्रॉल कम करो, फिर एस्पिरिन ऐड करो, फिर पैर चेक करो। इतना सारा बढ़ा दिया हमारे सिर के अंदर के चेक रही हूँ मैं, 5वां पॉइंट मिस ना करूँ, 4था पॉइंट मिस ना करूँ, तो इसमें लगे रहते हैं। और पेशेंट की कहानी हम सुनते भी नहीं है। शायद वो पेशेंट आया है आपको किसी पैर में कुछ घाव दिखाने के लिए, वो घाव ना हो, लेट इट नॉट बी अ घाव एट ऑल, लेट इट जस्ट बी अ स्पॉट, राइट। जो पेशेंट उस दिन आपके लिए आया है उसको अगर आपने पहले ही बात कर लिया तो पेशेंट खुश, you can go back to your checklist to do what you want. So listening to what the patient's concern for that particular consult by asking a straightforward question, what should we address today? आप मेरे पास किस कारण के लिए आए हैं? Finished. You have just dealt with it and got it out of the way. Patient told the most important concern for the consult and finished. Then you can go back to your checklist and so and many constraints for doctors, right? Doctors don't work in utopian circumstances, right? We are working in extraordinary circumstances. India में डॉक्टर खूब खराब है। 1000 पेशेंट्स अपॉइंटमेंट के लिए बैठे हैं, तुम हर पेशेंट के साथ आधा घंटा थोड़ी बात कर सकते हो, बट हमारी आर्ग्यूमेंट ये है कि तुम भी बात करो पेशेंट के साथ। वो 3 मिनट इंपॉर्टेंट हो जाता है, जितना कम टाइम मिले उतना इंपॉर्टेंट कम्युनिकेशन बन जाता है। तो सो यू कैन सक्सेंटली गेट योर पॉइंट अक्रॉस and still may affect one behavior change, because diabetes is all about behavior change. So we are not just prescribing medications, we are also trying to change behavior and change. How will we do that if we've not established a connect with your patient at all? So we understood many constraints. One was the many patients waiting, two, that many doctors are juggling. We are trying to do IPD, OPD, classes, conferences, many things. So we thought we had to represent this side of the story. But the main important learning from that survey was all doctors whether did say that yes, communication skills are important. No, we did not get any training for it in school. Yes, maybe I should pay some attention to improve from that point. Very reassuring learning that we got from that survey, Dr. Sanjay Reddy.
Thank you, Dr. Chitra and Tejal, for sharing the results of both doctors and patients in the survey, especially even from the doctors. Maybe there are many aspects to it, not a right atmosphere, not the right number of patients, nothing is an idealistic scenario, but the 3 minutes which you give to your person with diabetes or person with whatever he walks in, listening to him and probably addressing the black spot on the toe. That is what his complaint is, not the high blood pressure. First talk about it, then we will talk about the blood glucose. So the idea is first listen to his complaint. Taking this, Dr. Tejal, I have a question. One of the commonest scenarios are when patients walk in with high blood glucoses, like 12, 15, 16, you don't know, whatever the A1C, and you've been seeing them regularly. Suddenly this has gone out of time. Are you displeased, and how often, and how do, as a doctor, how to react, how to communicate this nicely? Okay, you come with high blood sugar, or maybe the first time he's walking into your clinic, somebody's, we're not trying to say that where he got treated earlier, they've done a bad job. But for various reasons, the sugar is bad. He walks in at the end of the day, when you're finishing your clinic, where you have to get home, probably your son is waiting, you have to pick him up, he walks in. How do you handle a scenario like this? These are everyday common scenarios. Are you displeased? How do you communicate this?
So, first of all, I think I have to be now a good actress also, along with being a good communicator. So, मैं हिंदी में जवाब देने वाली हूँ. So, basically, पहले मैं ये कहना चाहती हूँ कि हम कैसे बिहेव करते हैं. तो हम रिपोर्ट देखते हैं 350, 450. ओ माय गॉड, इतना ज्यादा ब्लड शुगर. तुमने पक्का गोली नहीं खाया है, या तो फिर डाइट में चीटिंग किया, या तो तुमने एक्सरसाइज नहीं किया. टेल मी व्हाई दिस शुगर इज सो हाई. ये मेरे को बिल्कुल नहीं चलेगा. अगर आपको मेरे शुगर कंट्रोल नहीं रखेंगे तो आप प्लीज दूसरे कोई डॉक्टर को दिखाइए, मैं आपको आइंदा से नहीं देखूंगा. This is normally the kind of reaction we give when somebody comes with a sugar of 350 and 450. मैंने क्या किया, पहले तो मैंने बहुत ज्यादा इमोशन से बात की कि वो ब्लड शुगर इज लाइक जैसे लाइफ एंड डेथ सिचुएशन है. तो पेशेंट तो ऑलरेडी डरा हुआ है, अब तो ये पूरा डर गया. वो तो पहले उसने रिपोर्ट देख के वो डरा हुआ था, अभी मैंने और डरा दिया. दूसरी चीज है, जैसे मैंने रिपोर्ट देखी, मैंने पेशेंट के ऊपर इल्जाम लगाया कि या तो उसने गोली नहीं खाई होगी, या तो उसने ठीक से खाना नहीं खाया होगा, या तो उसने एक्सरसाइज नहीं किया. तो नेक्स्ट स्टेप मैंने क्या किया, मैंने सीधे पेशेंट को ब्लेम कर दिया. और फिर तीसरी चीज, मैंने अपनी रिस्पॉन्सिबिलिटी छोड़ दी। मैंने तो अच्छा गोली लिखा था, मुझे नहीं पता तुमने क्या किया, ये तुम्हारा प्रॉब्लम है, तुम दूसरे डॉक्टर को देखो। आई एम नॉट सेइंग कि ये हम हमेशा करते हैं, बट एज यू सेड इट कुड बी द एंड ऑफ द क्लिनिक, मुझे मेरे बच्चे को पिकअप करना है, एंड मैंने ऑलरेडी 10 पेशेंट देखे आज जिनकी सबकी शुगर 400 थी, तो मेरा भी अभी पेशेंस खत्म हो गया है। बट व्हाट हैपेंस इज कि वो जो पेशेंट मेरे सामने बैठा है, उसके लिए तो आज दिन का पहला डॉक्टर है, उसने तो 10 डॉक्टरों को दिखाया नहीं है। इस मोड पे मैं डॉक्टर्स को ये कहना चाहती हूँ कि देखो, वो पेशेंट आपके सामने आके बैठा है, उसका ये मतलब है कि उसको उसकी शुगर की फिक्र है। अगर उसको उसकी शुगर की फिक्र नहीं होती तो वो डॉक्टर के पास ही नहीं आता, वो घर लेके जाता, वो रिपोर्ट चुपचाप वो तकिए के नीचे रख के सो जाता था। तो सबसे पहले जब हम ये सोचते कि पेशेंट इतनी लापरवाही कैसे कर सकता है, तो ये लापरवाही नहीं है। हमको ऐसे लगता है पेशेंट को अपनी जान की नहीं पड़ी है, लेकिन ये सच नहीं है। तो वो खराब रिपोर्ट भी लेके आया है आपके पास, उसका ये मतलब है कि वो आपसे मदद मांग रहा है कि डॉक्टर शुगर बहुत ज्यादा है, प्लीज मेरी मदद करिए। सो दैट इज द फर्स्ट थिंग। सेकेंड चीज है कि उसको डायरेक्टली ब्लेम करने से पहले अगर मैंने उसको पूछा रहता कि अरे मिस्टर सिन्हा, आपकी शुगर काफी बढ़ी हुई है, कोई प्रॉब्लम थी क्या? और अभी इस कोविड के जमाने में ऐसे ऐसे जवाब मिलते हैं, मेरा 40 साल का बेटा मर गया, मेरी परसों मेरी बेटी को ये हो गया, मेरे ग्रैंडफादर मर गए, इतनी ट्रैजिक स्टोरीज निकलती है। मुझे याद है एक लेडी थी जिसके हस्बैंड का ना शुगर लो हो रहा था, और मैंने उसको डांटा, मैंने बोला आप क्यों नहीं आए दिखाने के लिए? और उसने बहुत धीरे से बोला कि उस टाइम पे मेरा 40 साल का बेटा आईसीयू में था, उसको ऑक्सीजन लगा था, वो वेंटिलेटर पे चला गया और वो मर गया। तो डॉक्टर यस डेफिनेटली पेशेंट का अच्छा चाहता है, लेकिन उसको पूछो तो जरा कि क्या प्रॉब्लम थी कि शुगर इतनी ज्यादा आई। वो सेकंड चीज है। तीसरी चीज है कि ऐसा भी हो सकता है कि पेशेंट ने सब कुछ परफेक्टली किया है, फिर भी शुगर ज्यादा है, इसीलिए तो डायबिटीज कहते हैं। अगर वो आसानी से कंट्रोल होता तो वो डायबिटीज ही नहीं होता। सो मे बी पेशेंट को प्यार से पूछना कि अरे मिस्टर सिन्हा, आपकी शुगर थोड़ी ज्यादा है, क्या आपको पता है कि शुगर क्यों इतनी ज्यादा हो गई? कुछ प्रॉब्लम थी, आप गोली नहीं ले पाए, या आपको कुछ इश्यू था? फिर मोस्ट ऑफ द टाइम पेशेंट सच कहता है कि नहीं डॉक्टर, मेरे घर में ऐसा हो गया था इसलिए मैं नहीं ले पाया, या ये प्रॉब्लम थी इसलिए मैं नहीं ले पाया। लेकिन अगर मैंने उसके ऊपर चिल्लाया है तो वो मुझे सच नहीं बताएगा। वो मन में क्या सोचेगा, अरे मैं कुछ भी बोलूंगा, ये वैसे भी चिल्लाने वाली है, जाने तो बोलने तो उसको जो बोलता है, मैं चुपचाप सुन के जाता, एंड विल नॉट टेल यू द ट्रूथ। बट अगर हम प्यार से, अगर मैं बात करूं, पेशेंट सच बताएगा, क्या एक्चुअल प्रॉब्लम थी वो बताएगा, और फिर मैं हम दोनों मिल के उसका सोल्यूशन निकाल सकते हैं कि अगर आपको एक्सरसाइज का टाइम नहीं है तो आप शाम को आधा घंटा जा सकते हैं क्या? आपके घर में खाना कौन बनाता है, उसको हम समझा सकते हैं क्या? सो प्यार से, ओपन वे में, नॉन जजमेंटल मैनर में, गुस्सा ना करते हुए अगर हम क्वेश्चन पूछे तो हमको सच जवाब आएगा, और फिर आप सच में आपके पेशेंट की मदद कर सकेंगे। This is what I think.
Thank you, Dr. Tejal. I just wanted to share Dr. Neeta's comment, which has come in, and I think it's apt. Some patients can be each patient. Everything doesn't fit into a glove. मतलब patient भी अलग तरफ की होते हैं. So some patients, the best way is what you told. It's nice. Have the time, cajole them. It's very few at some point maybe threatened. Not threatened, that's not the right way to do it. Meaning to say, told that can lead to bad, if it's the second or third time it is repeated. Third, some people have to be explained very scientifically. There's a science guy who's sitting. So every patient is different. He needs one. We need to take an approach. But the best approach is the one which is with trust, with a lot of patience and a lot of understanding, trying to understand the patient. But everything is different. Now, there's another important thing which I wanted to take up and talk to you, and Chitra, is thanks, Tejal, for really giving us that summary of a perspective of what happens in the clinic, and pointing out where we do these mistakes and how we can really make it better. And also shared Neeta's perspective as they are different. Everything doesn't fit one. They're different sizes for everybody, and these people have to be communicated in a different way, but with the right type of language. Chitra, I have another common question. Many of us try to frighten our patients. I have some scenarios. a TSH of 5. Somebody has told a pregnant girl walking into the clinic, "Oh, this is the end of the world. Your TSH is 5 first trimester." Then she's so concerned about her mother. A gestational diabetes, a pregnant mother walking into the clinic with sugars which are high, probably gestational diabetes, very worried. Already the baddest things have been told to her, that this child is going to be affected, and this is one. The third is a scenario where we tend to sometimes tell patients, probably talk about dreadful complications first, even before we are trying to tell them the importance or explain to them. How do patients react, and how do we go about these type of scenarios?
Thanks, I completely get it. So, Dr. Neeta's intention is to get her person sitting in front of her to understand that the high does have consequences. And she wants to be absolutely clear that she communicates that there are consequences to those high blood sugar and that he understands that they can be severe. We all do that. We all want that. It comes from a very, very good place, right? And we also seem to think that scaring people is somehow a thing that we can all do and get away. And it was a strong theme which came out of all discussions that we did. That scaring me has already created this psychosis kind of an environment, which is the one which stops me from seeking. One young CEO always, even before teleconsultation was okay, would just want to request, he's also a friend of mine, and request me to, send out a prescription with his driver, right? And not at all ever want to visit me in the clinic. And once I told him that, listen, you have to come into the clinic, right? There is whole conversation does bring, we'll be able to do a better examination, we'll be able to probably discuss certain issues which are holding you back. He said, in your waiting room, you make me wait for about 2 hours. In your waiting room, there's a person in a wheelchair with one leg cut off. There's another person who's all swollen up and puffed up, and I know that he's having renal failure. And I know another person who's just, across the room, not able to see clearly. And when I sit there, it's a constant reminder of all the things that can go wrong to me, right? And it may like I am going to, my future is bleak, and that it takes away from my rest of my life. Yes, I have diabetes, but I also want to live a healthy life. I also want. So when we try and scare people, we might be deterring them from seeking help when they actually should be seeking help. Then how do you get the point across without scaring them, right? So probability of risk of disease, instead of saying पक्का आपका किडनी फेलियर होगा, we do use this word, right? Definitely आपका हार्ट अटैक होगा, इतने ज्यादा शुगर और कोलेस्ट्रॉल, पक्का आपका. Don't use absolute terms like that which make doom definitive. Doom is not definitive. We are not gods. And that being said, we also can't save everybody. Also something that we think we are gods, we are not gods. So it's important to say that if we bring your HbA1c down, we can make sure that your heart, eye, and kidneys are all safe 20 years from now. So I have said the same thing, but I have not spelt doom. I have told him that if we make his HbA1c better, his overall health, including his heart and kidney, is going to be fine. So I offered hope as compared to spelling doom. And I think that's an important thing to do. There's enough things scaring her. I'm worried if my parents will fall ill. I'm worried if I'll be able to pay my EMI. I'm worried if drugs. I'm worried about 1,000 different things. And I don't need somebody to spell doom every 3 months when I come in to meet you saying kidney fail ho sakta hai, heart fail ho sakta hai. So I think that is also something which we need to think from, right? So spelling doom is definitely something जो सारे पेशेंट ने बताया कि ये हमको बिल्कुल ठीक नहीं लगा, तो ये करके तो हमें टेंशन ज्यादा दे रहे हैं, फिर बाद में बोल रहे हैं कि टेंशन किया तो शुगर का टेंशन दे रहे हैं मुझे इतनी सारी बात सुना के. So that was a common theme which came out of our discussions, and discussing consequences was a very crucial point pointed out by our everybody should probably go back and audit and review some of the words that we use in our clinic. Tejal and I went back and did that, and we caught ourselves doing many things which our patients had pointed out to.
Yeah.
Come back and said, God,
True.
dude. Yeah.
I definitely agree, and most of us fail to sometimes honestly agree what mistakes we have done, and I accept that, and I think everybody should come out in the open and say and share the best practices. Dr. Neeta and I also did a role play sometime in RSSDI as to say how a good doctor versus a bad doctor, how just on the communication skills. Now, the other question, and thanks for sharing this. Hope is better than doom. Better create a hope rather than the doomsday which you want to create for. So let's take it, create hope for everybody, and the hope is always encouraging. Now, Dr. Tejal, I have a question, and this is something all of us do every day. Patient walks in, we need to start insulin, and that's the treatment you want to prescribe, and then we have both the doctor and the patient dreading how this communication goes on. So how do there are many ways, and everybody has their own way of trying to teach patients and so on. These common things which most patients and doctors do it.
So,
some do it very right. Some your experience.
Yeah, so of course I'm going to answer in Hindi again, but मैं ये कहना चाहती हूँ कि इंसुलिन जब शुरू करना होता है, शायद डॉक्टर तो पेशेंट से ज्यादा डरा हुआ है, बिकॉज अल्टीमेटली ऐसा होता है कि डॉक्टर को लिटरली भीख मांगनी पड़ती है कि प्लीज आप ये ले लो क्योंकि ये आपके अच्छे के लिए है. तो कभी कभी ऐसा लगता है कि हम इंसुलिन अपनी खुशी के लिए दे रहे हैं पेशेंट को. तो सबसे पहले मैं ये कहना चाहती हूँ कि जो भी पेशेंट ये सुन रहे हैं कि हमको किसी को इंसुलिन लिख के कोई मजा नहीं आता है, हमको कुछ खुशी नहीं मिलती है, और वेरी फ्रैंकली जब भी मुझे एक पेशेंट को इंसुलिन शुरू करना पड़ता है, उसका ये मतलब है कि मुझे इस पेशेंट को और एक्स्ट्रा 20-25 मिनट देनी पड़ेगी, जो मेरे पास है नहीं देने के लिए. बहुत सारे पेशेंट है और बहुत सारे मेरे टाइम पे डिमांड्स है. तो अगर कोई डॉक्टर आपको कह रहा है कि आपको इंसुलिन की जरूरत है, उसका ये मतलब नहीं है कि डॉक्टर को इंसुलिन लिख के कुछ खुशी मिल रही है, वो आपका कुछ नुकसान करना चाहते हैं. इनफैक्ट उनके लिए ये बहुत बड़ा एफर्ट है, क्योंकि अगर हम इंसुलिन शुरू करेंगे तो डॉक्टर को आपको बहुत कुछ समझाना पड़ता है ताकि आप इंसुलिन सही तरीके से इस्तेमाल कर सकें. लेकिन ये मैं जरूर मानती हूँ कि कभी कभी जब शुगर कंट्रोल नहीं होती है तो हम ये कहते हैं कि अगर इस बार तुमने शुगर कंट्रोल नहीं करी ना तो मैं इंसुलिन शुरू कर दूंगी. तो समहाउ मुझे ऐसे लगता है कि ये एक धमकी हो जाती है कि तुमने सब कुछ ठीक से नहीं किया है और इसकी वजह से ये पनिशमेंट है कि आपको इंसुलिन मिलेगा. तो ये मैं डॉक्टर्स को जरूर कहना चाहूंगी कि इंसुलिन को कभी भी एक धमकी जैसे नहीं इस्तेमाल किया जाए. इंसुलिन की बात बहुत पहले से शुरू हो जानी चाहिए. बहुत बार ऐसा होता है कि हम अचानक से इंसुलिन बोल देते तो पेशेंट एकाएक बहुत डर जाता है. अगर हम हमारे कॉन्वर्सेशन में शुरुआत से इंसुलिन की बात थोड़ी थोड़ी शुरू कर दे, जब डायग्नोसिस होता है, डायबिटीज के 2-3 साल हुए हैं, 5-6 साल हुए हैं, तभी से हम थोड़ी थोड़ी अगर इंसुलिन की बात करना शुरू करें तो ये जरूर मुझे लगता है कि पेशेंट के लिए ज्यादा डरावना नहीं होगा. तीसरी चीज मैं ये कहना चाहती हूँ कि जब भी आप इंसुलिन के बारे में किसी पेशेंट के साथ बात करते हैं, मुझे लगता है कि साइंटिफिक तरीके से बात करनी चाहिए. जैसे चित्रा ने कहा कि वो एक मरा हुआ घोड़ा है, फिर आप उसको चाबुक लगा रहे हैं तो गोली चाबुक है, और चाबुक मारने के बाद भी घोड़ा नहीं चल रहा है. सो पेशेंट बिल्कुल कंफ्यूज्ड है कि इसका मतलब क्या, ये घोड़े की क्यों बात कर रही है. तो हमको ऐसे लग रहा है कि हम बहुत सही तरीके से एकदम स्मार्टली समझा रहे हैं, पेशेंट को कुछ नहीं समझ में आ रहा है. और एक एग्जांपल था, किसी ने दूध उबालने के बारे में बात की कि वो दूध लेना है, फिर बर्तन में दूध कम हो गया तो हम बाहर से दूध ले रहे हैं. दूध, दही, घोड़े, भैंस की बात नहीं करनी है. हमको साइंटिफिक तरीके में पेशेंट को इंसुलिन के बारे में समझाना है. हम इस तरीके से जरूर समझा सकते हैं कि हमारे शरीर में इंसुलिन अभी बन रहा है, और ये जो बाहर से हम आपको इंसुलिन देंगे ये हमारे हेल्थ के लिए है, आपके बॉडी को सपोर्ट करेगा और आपके बॉडी को अच्छा हेल्थ देगा. अगर हम पॉजिटिव टर्म्स में इंसुलिन के बारे में बात करेंगे तो पेशेंट जरूर ये समझेगा कि उसको इंसुलिन की जरूरत है. मुझे लगता है कि प्रॉब्लम कहाँ आता है कि मैंने इंसुलिन बोल दिया और मैं एक्सपेक्ट करती हूँ कि पेशेंट ने तुरंत उसको लेना चाहिए. कभी कभी इंसुलिन को एक्सेप्ट करने को समय लगता है. आप पेशेंट को इंसुलिन के बारे में समझाइए, उसको बताइए कि आप इसके बारे में सोचिए, आप वापस जाइए. अगर आपको और थोड़ा एक्सरसाइज डाइट आपको लगता है कि कम पड़ रही है, आप 15-20 दिन में करके देखिए, और इसके बाद भी अगर शुगर कंट्रोल नहीं होगी तो हम फिर से इंसुलिन की बात करेंगे। इसी कंसल्टेशन में जबरदस्ती से इंसुलिन दे के ही भेजना है, ऐसा ज़रूरी नहीं है। एंड लास्ट चीज़ मैं ये कहना चाहती हूँ कि डॉक्टर भगवान 100% नहीं है। तो अगर किसी पेशेंट को इंसुलिन नहीं लेना है, वो अल्टीमेटली उसकी चॉइस है। आपका काम है उसको बताना कि ये ज़रूरी है। आपका काम है बताना कि इंसुलिन नहीं लेंगे और शुगर नहीं कंट्रोल होगा, तो उनको आगे तकलीफ हो सकती है। अल्टीमेटली वो उसका चॉइस है। आप आपके पेपर पे लिख दीजिए कि आपने इंसुलिन का ऑप्शन दिया था और पेशेंट इस समय इसको लेने के लिए तैयार नहीं है, और फिर आप उसको अपने हाल पे छोड़ दीजिए। बिकॉज़ हर कोई इंसान जो डॉक्टर के पास आता है वो छोटा बच्चा नहीं है, वो अपने डिसीजन खुद ले सकता है। और अगर वो चूज़ करता है इंसुलिन नहीं लेना, तो गुस्सा होने या अपना ईगो हर्ट हो जाना और उसको उल्टी-सीधी बातें कहना, उससे अच्छा मुझे लगता है कि आप छोड़ दीजिए। पेशेंट और 2-3 डॉक्टर के पास जाएगा, जब हर जगह से वही जवाब मिलेगा, उसको समझ में आ जाएगा कि वो जो डॉक्टर ने कहा था, वो सही कहा था, शायद मैंने उसी समय इंसुलिन ले लेना चाहिए। बट हम कोई स्कूल नहीं चला रहे, हम कोई स्कूल के प्रिंसिपल नहीं है। अगर बच्चे मिसबिहेव करना चाहते तो हमारा काम नहीं है कि छड़ी लेके उनके पीछे भागना।
Thank you, Dr. Tejal. Very nicely explained as to say, yes, we need to stop insulin, but better explain it in a scientific way and not using animals, food, or any other example as which we used to do. Probably
And yes, and these are all truthful examples. We are not making them up.
Don't even, yeah, I'm not even trying to say they are not made up at all. They are the most common examples which have been given.
Yes.
And thanks for sharing it. Let us become a little more evolved in trying to say how scientifically we can explain. Probably you may have a lot of models, a lot of videos are available to show them, to use interactive media also to tell them that this is what happens. This is not, and you should start the dialogue much early in the disease process than later. Third, give them time. It is not one day decision. For certain, give them time, explain to them, they can come back, rediscuss it, and then take it. It's not that it is going to hurt you today, that if they're not going to, and we're not school principals, definitely. You never listen to anybody of them. Where is the question? They're going to listen to you. But anyway, the duty for us is to make sure that you tell right. Now, Dr. Chitra, I have a small 2-3 questions. One, Dr. Pankaj had another. The three. This is aspect of the family. When you have to see when we treat patients in especially in our setup, most of the time they're accompanied by their family members. Nobody there's for one patient there are two attendants at my clinic. I make sure please one of you come, but sometimes there are two, sometimes three people also accompanying. It's a normal scenario. And now one of them whispers into your ear before the patient comes in, doctor, इसको डराओ, इसको डराओ. So this is one of the
No.
no, I'm telling you, इसको डराओ. They say इसको डराओ, कुछ खाना है, वो शुगर कंट्रोल में नहीं रहे. Second, then the other thing is when two parents, both are diabetic, come in with a child. Now you look at the child, you want to say something because you're scientific, right? Your two parents are sitting in front of you. Okay, your child may get diabetes. So in front of the child who can't understand, probably who's in his 10 or 12 years or 13 years, looking chubby, nice. I like many parents would want their children in our country to be. And what happens at that point of time? How do we communicate this to a child, to the parents, as well as these scenarios which come in where somebody says, "Oh, sir, usko darao." This is a common scenario, and
Yes.
how best to tackle this?
So I'll start with isko darao. I'll start. So I know
Nanda.
IDF had a theme one of these last few years which said that the whole family contributes to the treatment of diabetes, but I hope they meant it work together for the better results, right? So we have seen all combinations. I don't have to tell the audience that the overbearing wife who just wants to say sweets mein raat ko subah mein खाली रहती है, and or the husband who says walking ही नहीं जाती है, सारा दिन सीरियल देखती है. So we've seen all of this. We also have situations where kids come in. She doesn't listen at all. She wants to eat 5 chapatis. These are very, very emotionally charged also potentially volatile. It's not just about health, it is so much about power. I think it's more the power dynamics between that relationship, which they are trying to, while they come in for diabetes care. So you have to tread, I think, extremely carefully when you go down that route. And many times, many times, even though you feel like the giving the better, more real picture of what's going on at home, you still have to side with your patient.
Correct.
I think that's my takeaway. So HbA1c is high, you know it, patient knows it, you know that the patient's HbA1c is worsened with time, and you probably, it's very likely that the sweets have gone missing, but your consultation is with the patient, not with the patient's spouse. So they have to go to a marital counselor to sort out their issues. We are here to sort out that person's issues. So that, I think, is a message how to handle that dynamic per se. Many times I've told people to please allow me to speak to the person who's sitting in front of me first. I will speak to you at the end of it. But the first slot goes to the patient all the time. Coming to the other scenario where we want to be nice human beings and we look like that at the protruding abdomen of the child and say, Mummy, पापा दोनों को शुगर है, तुमने शुगर चेक किया? That, I think, is not at all being scientific or helpful. Okay, and I think we had many debates, Bharti Shashadri, who highlighted this point to us, which Tejal and I had not thought about before. Again, the same thing. Your nata is with the patient that you are treating. As much doing balai for the entire family by asking the 35-year-old obese son to check for his sugars, you are still stepping out of what is allowed by you have with your patient. That is what Dr. Krishna Shashadri highlighted to us, and I think it is a valid point. We should focus on sticking to our business. Of course, this sentence is so loaded. Blame, guilt, tujhe to pakka diabetes aayega, and all of that. What we had thought of is when we say check kiya, you're saying, definitely I'm expecting it to be high, you better check. The conversations that we thought of is, it is better to screen. A lot of diabetes is asymptomatic. So use all of those. Again, hope. So when you go with hope, you will talk about weak pre-diabetes, and pre-diabetes is more easier to push into remission than diabetes itself. The earlier we find diabetes, the earlier we institute lifestyle changes, we can prevent diabetes. Going back to Dr. Krishna Shashadri's word, that maybe you're overstepping by asking every other family member to screen for diabetes. I don't know if everybody agrees or if Dr. Sanjay Reddy agrees as well.
No, I definitely agree with you, because until you're asked for help, sometimes it becomes a little dicey. And I have scenarios in where if you go into that space, you're going to end up sometime it gets to a conversation where all of them start blaming each other at the clinic. So you don't want
Correct.
that to happen. Then you can call the gentleman. Can you come in? What I do is in a different. I learned this later, not now. If the son is there and I want to tell him something, then our father goes away. I say, can you wait? I need to talk something to you. So they appreciate this much better. I think it's better since both parents are. So it's better for you also at some point of time to screen yourself, because this is what is the scientific data. It would help you. That's all. Just one statement. If you do it in front of the parents, of the parents, it doesn't make a lot of. Sometimes he doesn't like it. He got it. So there's a blame game which is happening. We don't know the family.
Absolutely.
Never get into that.
Absolutely.
So, Chitra knows my favorite patient, Mr. Manjunath Dixit. I don't know if he's listening to this broadcast. तो Mr. Dixit ने हमको इतना सुंदर तरीके से सिखाया ये फैमिली और डायबिटीज के बारे में. तो मिस्टर दीक्षित एक बड़ी कंपनी चलाते हैं, बहुत अच्छी पोजीशन पे है, और उनकी मम्मी को डायबिटीज था. तो जब भी वो मम्मी को डॉक्टर के पास लेके जाते थे, डॉक्टर उनको हमेशा कहते थे, तुम ध्यान रखना, को डायबिटीज हो जाएगा. तुम्हारी मम्मी को देखा है ना कितनी मोटी है, तुमको भी डायबिटीज हो जाएगा. मिस्टर दीक्षित ने इतना अच्छा पॉइंट रेज किया. उन्होंने ये कहा कि डॉक्टर ने मुझे डायबिटीज के रिस्क के बारे में कहा, उसका मुझे बुरा नहीं लगा, लेकिन डॉक्टर ने जिस तरीके से कम्युनिकेट किया उसका ये मतलब था कि ये एक इनएविटेबल चीज है, मुझे होने ही वाला है और ये अच्छा नहीं होने वाला। अगर डॉक्टर ने मुझे ये कहा होता कि देखिए आप यंगर हैं, आपके टाइम में साइंस ज्यादा एडवांस्ड है और अभी हमारे पास बहुत अच्छी दवाइयां हैं, बहुत अच्छे साधन हैं, हम आपका डायबिटीज जल्दी पकड़ सकते हैं, अच्छे से ट्रीटमेंट कर सकते हैं। तो अगर आप ध्यान रखेंगे और समय पे डॉक्टर को मिलेंगे तो आप आपकी मम्मी के जैसे कभी नहीं होंगे। सेम चीज है, आपने रिस्क बताया लेकिन एक में आपने उसको नरक में धकेल दिया कि तुमको डायबिटीज होना ही और तुम मरने वाले हो, बिल्कुल अपनी माँ के जैसे। और दूसरे तरीके पे आपने उसको ऐसा बोला कि आप चिंता मत करिए, अभी की दवाइयां बहुत अच्छी हैं, आपको कुछ भी नहीं होगा, बस आप समय पे ट्रीटमेंट लीजिए, फॉलो अप करिए, सब अच्छा हो जाएगा। It is a difference between life and death, between heaven and hell. The same sin. And this is, I have to confess, my patient, Mr. Manjunath Dixit, I just consulted his father-in-law today, who is still following up with me. इन्होंने हमको ये सिखाया जो हमेशा मैं यूज करती हूँ अभी।
Thank you, Dr. Tejal. Just sharing what patients can teach us to in communication. And this experience, we have a lot of this happening. So I thought we had 45 minutes, but this can go on for another couple of hours. So what I would say is we'll call it a little early because we have another 3 minutes. So I would like to thank Tejal and Dr. Chitra and Purvi for putting this together and asking me to moderate. I learned a lot of things today. But what I can tell you is the most important thing to become a doctor is your passion is science, one. Second, read well, be a good academician, no doubt. But more than that, try to be a good human being. Try to be courteous. Show some kindness. Treat the patient sitting there. Imagine yourself in that chair someday. Only then, I always do this. I imagine myself on the other side of the room. So, saying this, also learn to be a good actor sometime. Probably we need to teach some dramatics. On the lighter note, probably learn dialogue delivery skills very well. If you do both of this, I think you'll be a good diabetologist or an endocrinologist because only thing we can do is talk at least. So, saying these few words, I would end with Mother Teresa's word. I wrote it down to say that kind words can be short and easy to speak, but these echoes are truly endless. That's what I can say. Be kind to your patients. I think that's what. Thank you, ladies. Thank you very much for being with us. And thank you for Purvi. I'll ask Purvi to end the session for today. We'll have more of these language matters in the days to come. Probably take it much better. We need to have more role plays. Probably 5 people attend doesn't matter. We'll still do it. Thanks.
I think
Over to you, Purvi.
you summed it up so well, Dr. Reddy, that there's not much left for me to say. This was a unique session and an absolutely eye-opening and a very, very thorough one. So I thought provoking for sure. And I think even all those patients who are watching today and logged in, I think it is going to be an important one to them also, that to know that the doctors who they go to are actually constantly thinking about them and thinking how they can improve patient care, not just in terms of the medical management, but also in terms of communicating with them better. So please be assured, we do think about you all the time, and do think about how we can improve our skills and how we can cater to your expectations better. Having said that, I think this was a fantastic start, and we must have more of these sessions. Absolutely vital to have these at regular intervals. And thank you, Dr. Tejal Lathia and Dr. Chitra Selvan, at such short notice to put this together, and Dr. Sanjay Reddy, even shorter notice, but what a fabulous job done. So, on behalf of RSSDI social media team, and of course from Dr. Banshi as well as Dr. Sanjay and the entire EC, we extend a very heartfelt thanks to you for the effort and for taking time to do this for us today. Thank you.
Thank you very much. Thank
Thank
you
you.
very much.
Thank you. Thank you. Thank you.